Okay, I think we'll kick off. So welcome and good afternoon, everyone. Well, here we go. The last, but not least, of our National Summit sessions. And it's going to be packed with some great takeaways for your organizations. My name is Kenny Butler, and I'm the Head of Health and Wellbeing Development for UK Active. The sector has had some positive news this week after a rollercoaster of challenges. I'm privileged and delighted to be in the presence virtually of so many of you in the sector. I'm also privileged to have with me today health leaders, charity influencers, authors, thought leaders. Over the last month or so, we've heard Andy Burnham speak of Greater Manchester's ambitious social prescribing plans in week 1. We've heard about the importance of data in week 2, and the sector has loads of that. Last week, it was the theme of placemaking for better social, economic, and public health outcomes. Today's session is going to explore how we can strive for a more preventative and joined-up approach to health and outline how you, the physical activity sector, can partner with other sectors and support the creation of healthier, more resilient communities. I'm very excited about this session today. This topic represents personal and professional passions of mine. I know most of the speakers and panelists, and I've been preaching to them over the years how the sector can support healthcare. And they have been listening. They're here and I haven't scared them away. Today represents a large-scale diversification of the future of fitness and leisure. This week, we saw stats on how exercise referral fell off the COVID cliff, with a huge decline in exercise referrals into our spaces due to being closed. We have heard the fitness and leisure industry in the sector being awarded as an essential service status in the prevention of treatment disease, as well as enhancing the health of the nation. We heard that 66% of cancer prehab occurs in our spaces. These can now resume soon. We know we can help with the backlog of rehab for elective surgeries and other types of rehab, and an ever-growing deconditioning crisis. Aggregated data from UK Active shows that, measured from July to October, gyms and leisure centres saw more than 45 million visits in the UK, with an overall rate of 0.99 cases per 100 visits. I think we're safe. We know that 17.1 million people reach the recommended levels of activity each week in our spaces, second only to walking. So there's an opportunity for our sector to develop and deliver innovative solutions to help us all stay active as we grow older. We also have a fantastic market opportunity further linking to healthcare. And hopefully you'll hear more about that today. So as far as the agenda goes, there's a great lineup today, as you see there. Today's session will be made up of 2 panel sessions with a short break in between, and the last one being open for Q&A. To round off the day, we'll also hear from UK Active CEO Hugh Edwards in light of what's happened this week. A little housekeeping. You know the drill right by now, I'm sure, with the webinars you've been on. You will be on mute. There will be some Q&A options in the chat, and the team and I will try to do the best we can to track those. If you drop out, don't panic. The same link can be used to come back in. And we will be recording this and share this with you on YouTube a little later. We're particularly grateful for the proactivity and support of the City of London Corporation. We should have been over there, but we're not. We are also grateful for our friends at Sport England, as well as our UK Active strategic partners listed there. You're all vital in making this event happen, so thanks for your generosity. A little bit about our active aging consultation, very related to this session and your role as healthcare providers, is what EGIM has done with us. They're helping us discover what the sector has been doing in the aging space. In partnership with EGM, we're undertaking a major new consultation to explore how the sector is supporting people over age 55 and those with long-term health conditions to lead an active lifestyle. Since October, we've been collating case studies, submissions for the fantastic offerings provided by the sector. We got over 100 submissions from the sector. My colleagues in the UK Active Research Institute have started analysing these in preparation for the second phase of the consultation, and that will be us gathering a group of older adults selected to best represent the individuals from this age group. And they'll be invited to take a part of qualitative research processes to further examine the sector's provision in this area. If you got any questions, please do email research@ukactive.org.uk. Now, I think it's time for some keynotes. Professor Chris Witte isn't someone I usually introduce every day. He has been a tiny bit busy recently, so very grateful that he has taken the time to send us this UK Active Fitness and Leisure Sector specific presentation that focuses on what we do. He's got other roles like Chief Scientific Advisor for the Department of Health and Social Care, and has overall responsibility for the department's research and development. He's also a practicing NHS consultant physician. Ladies and gentlemen, I would like to introduce England's Chief Medical Officer, Professor Chris Witte.
Good afternoon. I'm really delighted to be talking at this UK Active National Summit because, if we go on to the first slide, as we know, really since records began, people have known that having exercise is central to health, and it makes an enormous difference at every stage of life. And the more exercise people do within reason, the better for them. So what all of you do, and the way that all of you have approached this very difficult year in trying to actually be very ingenious in trying to find ways to encourage exercise through a very hard period for many people, has been absolutely critical to their health. And I'll come back to this at the end, but one of the real problems in 2020 is that one of the ways in which COVID has damaged health is for some people in making it more difficult for them to do exercise. And what all of you have done has helped to counteract that. The biggest impact of people exercising actually happens if they move from having almost no exercise to having a small amount of exercise. But as you steadily go up this graph, the more exercise you do, the greater the positive impact on health. And this has lifelong effects on people of a positive sort. If you just think about the life course, in early life, children and young adults should be exercising regularly and getting used to exercise. It helps build up their strength and muscles and bones all the way through the early course of their life. And then it's very important people maintain exercise through their adult life up to old age, because if they don't do that, the natural progression of people's strength, of their bone strength, and of their general cardiovascular health will gradually deteriorate at a much faster rate than if they're exercising all the way through it. And there are various life course events which, if we're not very careful, can interfere. Things like pregnancy, menopause, and changes in life circumstances. So all of these are things we need to think about as we try to encourage people to take exercise all the way through the life course. And then in older life, exercise is absolutely essential. And one of the things which I think we've increasingly recognized is not just exercise itself, but maintaining strength all the way through old age, because this is very central to being able to have a good and a healthy old age and minimize the risks of running into a whole variety of problems, ranging from simple things like trips and falls through to cardiovascular health. Last year, and in fact this is just before I took over as Chief Medical Officer, so I had nothing to do with these, so I can say this without any sense of trying to blow my own trumpet, a very good CMO report done by the 4 UK CMOs was released, and I would encourage anybody who has not read it, who's involved in this kind of work, to do so, because it goes through multiple areas in which health is improved by exercise all the way through the life course. But I wanted just to highlight a few points from it because I think they are important for all of us thinking about how to increase exercise across the life course for everybody. The first thing is that we really have moderate or strong evidence of how exercise improves health in children, in adulthood, and in older age. And I'm not going to read out all of these things, but there is no point in life where doing more exercise does not improve health in multiple ways, including, for many people, mental health. And much of the report concentrates on the areas, in a sense, people always think about. If you say to someone in the street, people should be doing more exercise, they often think of people in childhood or in young adulthood. But the thing which I really wanted to concentrate on in this section was just to talk a little bit about some of the groups it is really important we think through very hard in terms of trying to increase their ability to do exercise. The first are those with some degree of physical or mental disability. And it is extremely important that we work out ways to improve their ability to do exercise. At the elite end, things like the British Paralympic Association have done an absolutely remarkable job in highlighting how people can be extraordinary elite athletes with some degree of disability. But many people have disabilities, and that is an impediment to them being able to do exercise. So it is important we think how we can improve that. Then there are some particular points in life where there is a risk that if people are not given support to do exercise and to continue to do exercise, there is a risk that it will decrease. Pregnancy is one period of time, and continuing to exercise during pregnancy is essential for the health of the mother, both in the short and the longer term, and in the long term for the child. And then the period just after childbirth can be a very difficult time for men and women, but particularly often for women, to do exercise. And it is again important that we structure life in a way so that people can do exercise over this very important and difficult time of life to fit everything in. And then the other end of life, in old age, there are some inspirational examples, and this year Captain Tom Moore has very understandably captured the heart of the nation with his exercise in his 99th and then 100th year. And it is very important we see that it is central to a healthy and happy old age that people continue to exercise, and again we need to find ways to achieve that. Just two slides with some data on it. The first one is to recognize that it's not just periods of life that can matter. There are also particular difficulties for people, for example, who live in more deprived areas, who often have less access to open spaces or other places they can exercise, and certain ethnic groups can have, again, difficulty in exercising or having access to ways of exercising. And we need to think about that in planning how to support people to exercise all the way through society. And then finally, a point about COVID. COVID has made it a lot harder for many people to exercise. For some people, the amount of exercise has actually gone up. They've concentrated much of their leisure time on exercise, and that's, as everyone will know, been one of the exceptions which all the way through the COVID crisis has been a reason people have been encouraged to leave their houses, is to do exercise, particularly outdoors. But there's no doubt that the COVID crisis has made it harder for many people to do exercise, and it's certainly made it a lot harder for those who are involved in the professions and industries around trying to encourage and help support people to exercise and increase their strength. And I do think it is remarkable the way that the industry and professionals in this area have tried to find ways around this, accepting it is incredibly hard. And as we come out of the COVID crisis, which is not going to be immediate, but is going to be steady, we hope, probably from early 2021, spring is a point where I think many of us hope that things will begin to normalise, although not probably get straight back to normal in one bound. It is very important we try and get people who've got out of the habit of regular exercise back into a situation where they're doing so, and encourage others who've taken up exercise in a way they previously hadn't to continue to do so. So we need to think this through, all of us, because exercise is so central. But I'll finish really where I began. Exercise is probably the single simplest and most important thing people can do to improve their physical and mental health. And what all of you do to support people to achieve this is one of the best things for health in the UK. And I and everyone else who works in the health professions are very grateful about that. Thank you very much.
Well, that was great. And I'm sure Professor Witte would agree, a welcome break from the usual topic. He's flying the physical activity flag there for sure, and I'm sure you'll join me in saying we're quite appreciative of him being able to do that specifically for us in the time he's got. Exercise is probably the single simplest and most important thing people can do to improve their physical and mental health. That's powerful stuff, and then that's what we do, really. So I would like to move on now to Dr. Angela Spathru. She was part of this intriguing report called How Prioritizing Health Could Help Rebuild Economies. Do check it out. It resonates highly with the sector ambitions to be part of healthcare and help the nation build greater resilience. I've been referring to it since its release in July. Angela supports our national health systems in a variety of ways with a load of experience in integrated health management, long-term conditions, especially focusing on prevention of diseases like diabetes, obesity, and mental health issues. That sounds very relevant to today, and without further ado, I would like to pass you over to Dr. Spathru. Angela, are you there?
Thank you very much, Kenny. Thank you all very much. I think Charlotte is going to share the presentation. Perfect, thank you. So thank you very much, everyone. As Kenny mentioned, I'm a healthcare partner with McKinsey in London, and I lead the McKinsey Centre for Health Improvement in Europe. Over the past 20 years, I have worked with the NHS, but also with other health systems across Europe, North America, Australia, and elsewhere. And I think that has allowed me to see health systems at a critical time in their development, and also to appreciate the importance of not only the clinical services, but also the non-clinical drivers to health and well-being for our populations. So I would start by saying, and building very much on what Professor Witte just iterated, that the way we think about health and well-being in recent years has changed quite significantly. So if we take as an example the pandemic, early estimates in the pandemic suggest that the impact could be up to an 8% drop in global GDP in 2020. Yet, at the same time, poor health leads to reductions in global GDP, according to our analysis, of up to 15%. So what do we mean by that? If we move to the next page, this is a page that I imagine many people have seen in different formats, but there have been tremendous progresses. There has been tremendous progress in health outcomes and life expectancy in the 20th century and continuing with us now. If we go back even 200 years, we were at the point where the population globally was not more than 1 billion, life expectancy at 30 years. We are now at a population of 7.5 billion with life expectancy of close to 73 on average. And that obviously includes countries that are way above that, such as Japan, Switzerland, or Spain, that are closer to 83 or 84. So we are definitely living much longer now. But are we living well? Are we living better than before? So our work in the report Prioritizing Health, it was to quantify the upside of focusing on health as an investment with economic and social benefits rather than just a cost to manage. We believe that now, through COVID and post-COVID, as most health systems are reimagining what the health system of the future could look like and people try to rebuild the economy, we think there's a unique opportunity to not just restore what happened before, but really advance our understanding and value that we attribute to health and well-being for our population. So as part of the work, what we did was analyze almost 200 countries over two decades, projecting forward their outcomes up to 2040. Specifically, we looked at the top 50 diseases, more or less, that account for 80% of the global disease burden. We looked at if we could act on them with solutions that exist already today. We're not talking blue sky thinking, we're talking about available interventions, and scale those up in each health system. What could be the outcome in terms of reductions of mortality and disability, improvements in working population numbers, improvements in labor productivity, and obviously improvements in GDP. So what we found is, if we go into the next page, that we do live longer, but not necessarily always in better health. So we looked at the life expectancy gains of different countries, starting with Japan, as mentioned earlier. And as you can see here, the part in blue is extension of life expectancy, but in good health. So something that is not burdened by disease. And the part in gray is the part, unfortunately, where we are burdened by disease. And you can see that in a lot of countries, the gray part is quite big. In many cases, about half of the gain in life expectancy. In other cases, even more. So translating our advances in medicine and other means into longer life expectancy hasn't always led to this longer life being disease adjusted. If we go into the next page, what we looked at is specifically for the UK. So our report was global, but we did tailored studies for individual countries. And for the UK specifically, we found that 57%, close to 2/3 of the years lost due to poor health are actually occurring in the working age population. That means there is a significant loss there. First, there is people who, because of our failure to address certain elements of mortality and morbidity, are no longer there. Second, there is people who are part of our society, but are not part of the economically active population, although age-wise they could have because of disease. And then, of course, there is cases where we could be extending productive life into older age through better disease management, and that's also something we looked at. So what you see here is a cumulative impact of $505 billion. The study was done in US dollars, we can adapt the numbers, but $505 billion per year for the UK, and this does not include the cost of care for that population. If we go to the next page, what we also did was look ahead using the data from the Institute for Health Metrics and Evaluation in Washington. So looking ahead at the disease baseline forecast for the United Kingdom from now going up to 2040. So basically anything you see below the line are diseases and conditions whose relative weight, relative disease burden for the UK will decrease. But anything you see over are diseases and conditions that will actually increase. And of course, mental health disorders are up there, but also musculoskeletal disorders, neurological disorders, diabetes, cancers, and many others. So we looked at the burden of disease, projected that forward, and then came back to the discussion in 2040, if we go to the next slide, in 2040, based on the burden of disease we expect to have, and we used for that disability adjusted life years, dailies, we found out that about 1/3 of that disease burden, the projected increased disease burden for 2040, could actually be reduced with existing interventions. So obviously not all of it, but 1/3 is a significant amount, as you can see. So what we did on the back of that is to try to map what are these interventions and how they're clustered into groups so we could act on them as a society. So in the next slide, we have the listing of the interventions. So we have the different key categories. So the 3 big categories we used were environmental, social, and behavioral interventions. And things around exercise, well-being, weight loss, nutrition would come there. Broader prevention and health promotion, quite often disease-specific as a second bucket. And the third one was therapeutic. So what people typically would identify as clinical interventions provided in a clinical setting. So it will not come as a surprise after the discussions you've had this week, I imagine, but 2/3 of the improvement that we can offer in terms of known interventions by 2040 would come from the first 2. So from environmental, social, behavioral, and preventive interventions. And not, so basically the typical classical clinical side would represent only 1/3. So that is a pretty significant finding. And if we go to the next chart, there's quite a lot of data here. I will obviously not take you through all of that, but I think it's interesting to say in each one of those, we have the breakdown of the contribution in terms of daily reduction of years with disease. So some specific things such as smoking cessation and public health interventions are very well known and people would expect them. But what's interesting here is that exercise, workplace and home interventions, physical activity, diet, weight loss, all of these programs are about 40 to 45% of what we see in the first bucket, the environment, behavioral and social interventions. So right now we could argue we not only have a sense that certain things are helpful, but we actually have an estimate how many years ridden with disease we can reduce from our population if we were actually to take things at a more systematic level when it comes to exercise, nutrition, weight loss, and the overall well-being. Interestingly, we looked at this also across Europe. So in the next chart, we have the similar data for Western Europe. And we did indeed see exactly the same picture. So all the societies start from different starting places, and there's some commonalities. So something like diabetes prevention program was obviously the number one intervention in terms of potential dailies averted. Within that, though, physical exercise, weight management, lifestyle support for diet and activity, all of these things together are coming as a very close second, and one of the most significant and meaningful things we could be doing across Europe today. So as you'll see in the next chart, we are getting to a point where we can really push the boundaries of what it means to be an economically active and societally active member. So we say 65 is the new 55. What we have seen is that a 65-year-old in what we call the healthy growth scenario, so the scenario whereby our society has taken existing interventions and scaled them up, a 65-year-old in that scenario has the same likelihood to be as healthy as a 55-year-old in the baseline scenario, whereby we do nothing, we continue as is, and we have an increase in chronic disease, obesity, and related conditions at the rates that we have seen historically. So 65 is or could be the new 55, a very aspirational thought for our societies. And that is only with things that are already in the market. What you'll see in the next couple of pages is that we also looked at things that are in the pipeline. So if we go to the, thank you. Going forward, in various innovations that are in what we call the visible pipeline. So they're not sort of blue sky thinking, but are already being commercialized or being scaled up in different areas. This would include different aspects of genomics and molecular technologies, next generation pharmaceuticals, advanced surgery techniques, new vaccines, connected devices, electroceuticals, various types of implants. So as you'll see in the next page as well, this type of interventions that are coming in the next few years could further reduce the disease burden by 6 to 10%. So investing in innovation is going to be a significant part of our health and well-being going forward. So what does this mean then in terms of the economic impact, the impact on labor force, the impact on productivity? If we go to the next page, what we did here was map which age groups the different interventions could benefit the most. And what we found is that 55% of the potentially healthy life years, so life years without disease, without the burden of disease, would be added to those aged 70 and under, where the economic contribution would be the largest. So you can see here how this materializes for different types of population. There is, of course, significant impact after 60 and after 70, but close to 2/3 happens in the economically active population. So what this means in terms of the impact on labor force and impact on GDP. In the next slide, we have the analysis on what this could mean in terms of the impact on labor force. So here we start with the projected labor force for 2040, which is about 37.8 million. We are adding to that increases the population based on the different interventions we have discussed. So the first bucket is direct increase in the workforce for just improvements in healthcare. The second one is from reducing early deaths. The third one, under expanded participation, is increase in participation of older people in the workforce. The fourth is increase in participation of people with disability. And the last one, last but not least, actually quite significant in terms of size and importance, is the increasing participation of informal caregivers. So by keeping our population healthier, not only we increase their own participation in the workforce, but also we increase the participation of people caring for them. So we end up with a projected potential working population in 2040 of 40.9 million. So 3 million and a bit over what we originally had. So an increase of 8%. That is a pretty significant increase if you think that it relies on making the most of what we have as a population and encouraging people and supporting people to live their healthiest lives possible for the longest time possible. What this means in terms of GDP and economic impact, in the next page, we looked at, and this is something, as you will see in the report, that we did at a global level, but here we developed the card just for the UK so we could have this discussion today. So the base case GDP, so at 4.1 trillion effectively. If we added to that the different buckets we discussed, fewer health conditions, fewer early deaths, pretty significant contribution of expanded participation, so helping people lead productive lives longer, which also addresses, I guess, some of the pension crisis that we have as well, and higher productivity. You end up with a projected GDP that's significantly over. It's almost 400 billion over what it would have otherwise been by 2040, a 10% increase. And obviously an annual growth rate on a steady state from 1.4%, which is what we projected forward to 2040, all the way up to close to 2% in projected increase in GDP. So this is some fascinating numbers. For the eagle-eyed, you've probably seen that this 400 billion is lower than the 500 billion we mentioned earlier, but we have been conservative in assumptions, including that even if we scaled up fully these interventions, we wouldn't necessarily fully capture the full potential. So we have been fairly conservative in that one as well. But nonetheless, 400 billion, 10% increase in GDP, that is pretty substantial, pretty fundamental. And I think it proves beyond doubt that healthcare is no longer a side that is sometimes at the side of the economic dialogue, but is an intrinsic part of economic planning for our societies. So the obvious question, of course, at this point is yes, but what does this mean in practice? What would it cost? Or as many economist friends would like to think about it, what would be the return on investment? So if we go to the next page, what we did is we estimated what would be the likely cost of additional health spending, and then what could be the GDP impact. And again, for all of these cases, we have looked at different ranges, more conservative and more ambitious. So this is more of a moderated scenario. But the bottom line is, and I think a lot of friends in the health service will recognize these numbers, we estimated that for every dollar or pound equivalent invested in improving health, invested in creating more integrated health and care sector in our country, invested in increasing exercise, increasing well-being, increasing programs for weight loss, improving nutrition, and addressing all the societal, behavioral, environmental factors that we discussed. So for every $1 or £1, the economic return based on these numbers and the projected GDP impact could be almost 3 times as much. In fact, we had it at 3.4. So again, this is something that will generate a lot of discussion, but we think that has some very clear messages on what this could mean for us and for our societies. So I will close by saying we think this work confirms the huge potential we have to build a healthier society, focused on prevention, on care integration, empowering the population to take better care of their own health and well-being, and of course, empowering the carers to support their beloved ones in a better way. So if we look at the final page of the presentation, we concluded this work, the Prioritizing Health report at the global level, and with this interpretation for the UK, with some, in our mind, very clear imperatives for healthy growth. We believe it's very important to make healthy growth, and as a reminder, that means in our mind, fully deploying the different interventions we discussed and doing so in a scaled up manner across the country. Healthy growth is a social but also economic priority. We think a second imperative is making sure that health and well-being is on everyone's agenda, and it is very much part and much more strengthened part of what we do through every part of society, whether it is our employment place, whether it is through schools, whether it is through universities. Every part of society health and well-being should be on everyone's agenda. We believe there is a third imperative around transforming and integrating much more the health and social care and all the different readings that we have about the well-being of our population, in particular with the new data possibilities we have now. And last but not least, doubling down on innovation that will create even new and additional possibilities to reduce the disease burden, as we discussed, by an additional 6 to 10% versus what we have already projected under the healthy growth scenario. So we're very hopeful that coming after COVID-19, we will all prioritize health. We believe that both the UK and other countries have what it takes and will ultimately be able to rise to this opportunity to improve our health and well-being, and also help create even more sustainable and economically productive communities. Thank you very much.
Thank you very much, Angela. You and McKinsey have produced a fantastic piece of work there. The importance of that data cannot be underestimated. There's definitely conditions that you list there that we can support as an industry as well. Using interventions, I think you said, using interventions that already exist today, disease burden in the UK could be reduced by 1/3 over the next couple of decades. Yeah, surely the sector might be able to fit in there. We've got the technology, space, and people to assist that as well. Thank you very much, Angela. That was great. Angela from McKinsey. Superb. I will move on now to the next keynote we have. Patients know her as Dr. Helen, and she's on the front line and working as a GP. I've been privileged to work with her in her capacity as chair of the National Academy for Social Prescribing. And she's been with us before and captured the imagination of our sector elegantly at this exact event in person then. She's got many other accolades, but I know I'll embarrass her if I go on. So Helen, I might just hand over to you.
Thank you so much, Kenny, and thanks to all the brilliant UK Active team. Now, there are no fancy slides from me this time, no data, it's just me chatting to you. 10 minutes or so, and if we get some time, I'll take some personal questions, or I'll be on the panel later as well. And it is really wonderful to be here at last, but it's also really peculiar to be doing this remotely. And my extrovert personality has found this hard. I know it will have for you, because I want to be in a room with you all, as I was last year. Now, in the past year, I've taken on a really wonderful and special role in social prescribing. I chair a brand new organisation, the National Academy for Social Prescribing, now, which sounds rather grand, but it's a registered charity which works to bring together all interested parties in the social prescribing space, and I'm going to come back to it. But I'm also chair of the Academy of all the Medical Royal Colleges, so that's all medical doctors of every type in every setting. And as I'm still a frontline GP in the Midlands, I want to start by framing everything around the fact that we are now in this COVID-tinged world. When novel coronavirus 19 came into being, the world changed, and it changed forever. And it became a world where inequity and the social determinants of health have a very tangible and immediate adverse impact on survival from infection in the UK as well as all around the world. And as I'm on that role, can I suggest we drop the term post-COVID? We still hear people talk about it. There will not be any post-COVID. There's just going to be a new normal where COVID is part of our lives, a world where we've survived the pandemic, and goodness knows the news recently has given us great hope about vaccines and so on. So yes, post-pandemic, we'll have adapted our lives and our working practices at almost every level, and things just won't be quite the same again. So we're at an inflection point now, with the second wave of the pandemic well and truly on us. The end of EU transition deadlines are looming in a matter of weeks. And of course, the perennial winter pressures on healthcare. We are on the cusp of a perfect storm in our NHS. And consequently, those of us in England are in lockdown once more with ongoing uncertainty. And you've seen the headlines, they change day by day. We're on a roller coaster of good news and less good news. And I worry about the sustainability of our NHS in all 4 nations. What can we do to ensure that our comprehensive state-funded, amazing universal healthcare can endure for another 70 years? And I really believe that we need to rethink healthcare. or at least reframe it. Now, what I mean is, let's start with a citizen, the person in their own social domestic situation, empowered to live their best, their healthiest and most rewarding life, in warm, safe housing, with people who care for us, the chance to eat nutritious, healthy food, and to keep physically fit. These are the social determinants of our health, as the other two speakers have already alluded to. But then we move to the citizens who are based in the right environment, the right communities that support healthy, sustainable living. So that's involving local government, education, employment, and all the factors that impact on health inequalities, like access to green spaces, access to information, community assets in the way that people understand and can access. And then, when people need advice about basic healthcare and well-being, they're informed about where to go and how to get there. They're digitally supported and enabled, accurate, timely, personalised information at their fingertips, or available locally in a way that works for them. Then, when there really are medical issues, sort of when I come into it, the point at which people like me call everyone else patients, then people are in the best physical shape to start with. They'll do better in almost every measurable domain when they're unwell. Healthcare entry points need to be clear, unambiguous, easy to navigate, joined up, and people remain considered as a whole person through their entire medical journey, something we're not always very good at. And of course, when serious medical things are happening, the system responds to those appropriately, communicates seamlessly with itself and with the patient, and does what it needs to do, but always remembering the whole person. And the NHS and the care system doesn't treat people in parts for longer than it has to. So we shouldn't be thinking about single diseases. We need to keep thinking about the whole person. And that's what I call rethinking medicine. Start with the person, not with institutions. And of course, it's much bigger than medicine. It's a whole society approach. And actually, I don't think this is radical. It's common sense. And I hope that you get this. But actually, it is flipping much of the way our current structures are set up. Our structures that often start with big hospitals and super specialities and work from there. And we know there are myriad medical initiatives already doing this in the UK and worldwide. And in NHS England, you're going to hear later about the personalised care centre. We've got evidence-based interventions. We've got an over-medicalisation movement. Scotland has had realistic medicine, and in Wales, prudent healthcare. And all of these are a start of this. But I believe we can go further if we choose to. And I do believe that we have a once-in-a-generation opportunity to have an honest conversation about the care that doctors should and should not be delivering, where that care should take place, and what our patients should and shouldn't reasonably expect. So we start the medical journey with the citizen, not the institution, resetting our relationship with health and well-being, and rethinking medicine in a practical, accessible way. And this is where social prescribing comes in. You see, there was a point to all that. Now, I mentioned the National Academy for Social Prescribing, and we define social prescribing as the process of supporting people via social prescribing link workers to make community connections, to discover new opportunities, building on individual strengths and preferences to improve health and well-being. And we seek to ensure that everyone can access the support they need to help them live their best life, whatever their medical and care needs. And we've got a vision, and we've called it a social revolution in healthcare, and I'm proud of it. Now, as a GP, I've always known that to achieve the greatest medical success requires a complete understanding of the social elements of my patients' lives, not just the physical problems and psychological issues. And social prescribing has existed for as long as medical professionals, and indeed anyone who's got an insight into the human condition and gives advice, has been happening. Now, I do like to say that social prescribing is what GPs, religious leaders and bartenders and hairdressers have always done. In this audience, I want to say it's what health coaches and personal trainers have always done too. Help people to build relationships, unlock individual strengths, increase choice, control, and support community connections within the communities where people live. Starting with individual strengths rather than focusing on deficits, building confidence, demedicalizing solutions. It's about discovering and rediscovering the joy in life, trying something new, or building on a long forgotten talent. Finding help with things that are difficult, creating sustainable, supportive networks and relationships. So our stated aims as an Academy of Social Prescribing are to make some noise about it, promote it widely, raise the profile, and that's one of the reasons I'm here. But we also need to find resource and distribute it into communities, developing innovative funding partnerships, but build relationships across all sectors, and it's great working with you. Improving the evidence base is also important. We need to work with academic partners. We need to prove that what we're doing is the right thing. There's lots of evidence there. We need more, and we need it in a coherent way so that we can then spread the message about what truly works. And let's save people reinventing wheels when they don't need to. Now, to do all this requires every community in every corner of the nation to have a range of opportunities available to the population, so that there is the right resource for anyone who needs it, that's right for people, that there are thousands already out there. And we'll think of them in 4 main bundles when we talk about social prescribing. Now, some opportunities cover more than one of these areas, but we think of sport and exercise initiatives, green spaces, the great outdoors, arts and creative opportunities, and advice, support and guidance. So 4 bundles: sport and exercise, green space, arts and creative opportunities, and advice, support and guidance. And we're at a really exciting stage in the Academy, making partnerships across all those areas. And just this month, we've launched our Thriving Communities Network, and we've got lots of other exciting partnerships in the wings. And I'll just give you a quick spoiler alert: the panel discussion coming up is worth waiting for. But coming back to our COVID-tinged world, during the pandemic, where our gyms have been closed and even our green spaces were temporarily closed off, as Chris Witte alluded to, I was blown away by the innovation of our social prescribing link workers who moved into the virtual space. They picked up the phone and they started calling on the vulnerable, the isolated and the lonely. But others changed too. We saw how Joe Wicks inspired a nation to be more active, but that sparked lots of local initiatives too. Neighbours who'd been strangers set up support groups. People who'd ever known me, ever nodded just a polite hi, stopped and felt empowered to ask one another's names, to set up locality emergency support groups, which in turn have become befriending groups. Gyms have reached out into the community and helped people be active so that when things change again, we'll remember all these people and these connections. People of all ages and all walks of life have been connected by locality, because that's all they could access. And many wonderful and innovative schemes were born. Now, in other cases, large organisations have modified their offering and done great things. The South Bank Centre has started an Art by Post programme to bring art into the homes of lonely, isolated people. And I love the Breathe initiative from the English National Opera, a programme to help people recovering from COVID-19 practice breathing exercises through singing. Look it up, you will feel happier for doing so. We may be isolated, but we are not alone. We may be stuck at home, but we don't need to be inactive. And we may need to follow rules and restrict our activities, but we don't need to give up. You are creative, innovative people, and your organisations include a wonderful range of people with untapped talent. I'd suggest please create some space to allow their creativity out and have the courage to reach out to people and speak up for them, and you will be rewarded for it. Social prescribing is not mystical, it's not magical either. It's just the right thing to do, and it makes sense at every level. And I want you to know that by definition, you're already part of it. Look, you can tell I care about this stuff, but I know you care too, and your world and my world together make a far better world for everyone. A society that is more active, is fitter, that is healthier, is happier. So thank you all for letting me rabbit on. Kenny, I'll hand back to you, and should we throw it open to some questions?
Amazing, amazing. Thank you. Thank you very much, Helen. As usual, lots of food for thought there. And I love the social revolution for healthcare.
I do too.
Common sense, like that. Resetting a relationship with health and well-being. I think that's kind of what we're trying to do, isn't it? Link the industry to health in many ways. You know, one thing I will ask, Helen, is, you know, we're in high intensity industry, you know, lots of fit people. We keep many people getting the CMO guidelines that I mentioned earlier. But what about the others who aren't engaging with the sector? You know, what would you say to the audience about us engaging that audience, that community that's still not engaged with us?
So look, engagement's a two-way street, isn't it? I mean, if both the CMOs talk and Angela's talk beautifully illustrated to me this massive untapped opportunity that there is out there. There's a huge chunk of population who don't traditionally engage with your industry. And why is that? Many people that I see in my consulting room are intimidated by the thought of going to a gym. They're terrified because they look terrible in Lycra. They don't know what it involves. All they see are adverts of thin, beautiful people on very fast, high-speed exercise bikes on TV, which terrifies the bits out of them. Now, we all know differently. So there's something about reaching out to people, making it easy to people, being accessible to people, opening your doors. You know, when the time comes, do you have open days? Come and have a look around, no pressure, you know, have a look, demystifying it, speaking to people in the language they understand, and understanding that the vast majority of people are very insecure about their fitness, they're very insecure about the way they look. And you make yourself vulnerable when you seek help. So let's recognize that and embrace it. Now, some places do this amazingly, but if this isn't something that you've consciously thought about in your organization, I'm conscious you've got a huge range of organizations here, that would be something I would strongly encourage. You know, I kind of see it at the other end. I see the depression, the anxiety and the self-doubt and all those things, which are bundled up frequently with a lifestyle that isn't as active as it could be. And for so many of my patients, you know, the aspiration of the 150 minutes a week is fantastic, but that's terrifying to them. So for me, it's starting small, starting gentle. It's back to the whole personalization thing. If we put blanket things out there, we lose the vast majority of people. Great to have the targets, but it's how do you get there? How does the lonely person who's recently moved to the area, who doesn't know anybody, how do they take the first step through the door? How does the vulnerable person who's broken their hip and wants to get more active but has never stepped in a gym nor indeed bought any you know, exercise and sports kit in their life, how do they get started? Because once you start people, they become enthusiasts, and once they become enthusiasts, they're your greatest advocates, and they in turn can, you know, fly the flag for you. Sorry, that was too long an answer. I'll be quicker with the next question.
That's very thorough. I think just before we go off a break, I will give the Thriving Community Program a bit of a plug here that the National Academy has launched. It's about teaming up partnerships, isn't it? It's the local volunteer community, faith organizations, social enterprise, some of which our members are social enterprises, for instance. These are place-based partnerships, aren't they? This is the way social prescribing should work successfully, is about those kind of partnerships. Are you in agreement with that?
Absolutely. Place-based, ultra-local. I think, you know, you can have ultra-local through organizations that have many, many branches, but it is that ultra-locality of it that's so important. And what we know is getting a very modest amount of resource to many of these ultra-local things can have a disproportionately beneficial effect. And so we're very keen to help share good practice. So when there are people doing great stuff, we want to help them continue doing good stuff, but also how can we replicate what they've done and help spread it to others. I think I said about reinventing the wheel. So yeah, the Thriving Community Partnership is really exciting and is generating a lot of excitement. And one of the things we've done as an academy is set up as a regional structure. So we've split, you know, this is all starting in England, just to be clear, if we've got people from the devolved nations. And yet we are starting England-based because it was Department of Health and Social Care that gave us our grant to get us started. But social prescribing is not confined to England. It's not confined to the UK. We've got tons of excitement from around the world. People are really watching us because our NHS in the UK, in England, sorry, is the first to ever invest in social prescribing. So that's a kind of a side interest. But yeah, ultra-local communities, and just Google Thriving Communities, NASP, and it'll come up. There's quite a lot of good stuff on our website about it to get you started. Superb.
And we'll talk a little bit more about social prescribing after the break as well. Which brings us to 5-2. We're going to have a break up. I can't believe we're on time. It's my main role, my main job, I think, is to keep everybody on time. So we are on time. We're going to have a break now until 3 o'clock, people. So grab a cuppa or something, and we'll see you back at 3 o'clock. Thank you very much, Helen. Great. So hopefully you've all got your drinks and a little stand up, a little stretch, and welcome back. I think what we'll do is just make sure we got everybody in the panel. I believe we do. And Helen's going to be joining us again for the panel, alongside James Sanderson, Anna Dixon, and Warren Smith. But I'm going to let these guys introduce themselves, and then we can get into a little bit of discussion. So I think what I'd like to do, first of all, is just to have people just introduce themselves, just briefly, about them and the organization, and then we'll come back and we'll throw some questions around, shall we? James, are you there? Shall we start with you?
Hello, Kenny. Good afternoon, everybody. It's fantastic to be here. I'm James Sanderson. I'm Director of Personalised Care for NHS England and Improvement, and also the Chief Executive of the National Academy for Social Prescribing. Thank you very much.
Anna?
Hi everyone, my name's Anna Dixon. I'm Chief Executive of the Centre for Ageing Better. We're a charity funded by the National Lottery Community Fund, and we use evidence to influence policy and practice so more of us have a good later life.
And Warren.
Afternoon, everyone. My name's Warren Smythe. I'm Chief Executive of Abercroft Leisure. We're a charity based in Suffolk that provides facilities and services that support physical activity, and that ranges from your traditional leisure centre through to small community facilities, a range of initiatives, and even an outdoor education team.
Thank you very much, all. And we've heard from Helen already. We know who Helen is. I'd like to start with the questions. James, can I tee up one for you firstly, please? We've been working together for a while now, discussing the potential of the sector within your area of the NHS. Can you tell the audience a little bit about what our two organisations have been talking about, and what NHS England and your other role with the National Academy for Social Prescribing intend to do together?
Fantastic. Thanks very much, Kenny. And I have to say that the partnership that we've had with UK Active has been absolutely superb. I think it's a real meeting of minds, and this mutual commitment to support people, as Helen said, to live their best life. We've heard the science from the Chief Medical Officer and from Angela and from Helen around why physical exercise is important for health and well-being. And what we've been discussing between the NHS and National Academy and UK Active is how we can create a real innovative partnership to enable people to have the opportunity of experiencing physical exercise as part of their support plan. And we're really pleased to announce today a fantastic partnership where we're going to work towards a pledge for the fitness industry to provide 500,000 hours of free support to the NHS, administered through primary care, to enable link workers to use social prescribing to connect people with exercise and opportunity for fitness within an industry that understands how to support people in a really, really effective way. And I'm really grateful to UK Active and to all the partners that have joined this afternoon for this really generous offer. And I think it's the start of a new relationship where the NHS, having recognised that social prescribing and personalised care is really important for the future model that we're building, and within the long-term plan, we've committed to put in place 4,500 link workers, people that are dedicated, sitting in primary care, that have a responsibility to connect people to non-medical interventions. And as Helen said, whether that's the arts or the natural environment or advice and guidance, or indeed exercise, and sport and activity, it's such an important opportunity to get this right within a healthcare system. And we're the first health economy in the world to invest in psychosocial support for people in this really active way, and embedding it into the way in which we deliver general practice is really, really important. So today's announcement, this real innovative opportunity to link the NHS through primary care to the sports and leisure industry in a really active way that enables us to build programs, to build relationships at a community level, and start linking together all of the aspects in local communities that we know make people well. And that's a common goal that I think we all share here. We know that many people facing significant barriers to health and well-being, this is a perfect way of starting to break through those and create real opportunities for individuals.
Amazing. Yeah, it is. It's great to hear that, and it's been a long time coming, but it's a landmark partnership indeed, and it's a long-term view. We've been working on this for some time, so yeah, thanks for articulating that very well, James, and I'm sure we'll come back to that in a moment. Anna, I'd like to move on to you, and we'll open up some questions a little later as well, see what's going on in the Q&A. But we've had the privilege of being on a paper together, talking about how we can prevent and delay social care with physical activity, a focus on physical activity. UK Active and Centre for Aging Better have also done some work recently around 50 to 70-year-olds. And, you know, you've heard me refer to the active aging consultation today, which you guys have seen as well. So you've got an audience today that would love to know why it's so important to engage with this age group.
Well, thanks, Kenny. And yes, it's so important. We heard from McKinsey the data on the fact that we are living longer. We've been given this extra time, but we can only make the most of that if we're living those extra years in good health. And unfortunately, that isn't such a good story. We are actually seeing, particularly in poorer communities, people experiencing poor health and disability as early as their early 50s. And so physical activity could play a huge role, and does already, in helping people to enjoy a healthier, longer life. And that's not only good for those individuals. They can carry on, for example, working. We know that one of the leading reasons people drop out of work before state pension age is their health, or indeed caring responsibilities. It's important so they can volunteer. We again see that a difference between those in good health and those in poor health in the amount and number of people volunteering. And just generally being active in their communities and doing the things that we've been talking about that mean that they have their best life. So that's why at the Centre for Aging Better, we have prioritised physical activity as an area to focus on. We do focus on people approaching later life in that important life stage in their 50s and 60s. And why? Because we think we can do something then to really prevent. We see already the numbers of people inactive growing. And so, you know, that there is an age gradient, as we saw from Chris Witte's slides. And you know, we think that working with you and really seeing how you could extend your offer as a sector to the people who are 50 plus, I think we could really not only benefit them, but also benefit wider society.
Yeah, we're welcome to do that as well. Warren, thanks, Anna. You and many others in the audience have had some enormous challenges recently. At our active uprising in August, your colleague Matthew was alongside Helen's colleague Bev from the National Academy for Social Prescribing, talking about what Abercroft was doing in East Anglia around social prescribing in that space. Can you take me through some of the elements around your social prescribing program that is a formula that others might want to hear about, or how you arrived to this place?
Yeah, sure, Kenny. I think that the first point I make before we get to the social prescribing is some things we put in place about how we engage in the local system, for want of a better term, and actually how we've tried to embed ourselves in that process so it creates an opportunity for us to engage properly with the partners that are arranged around social prescribing and working in that space. So, and I acknowledge there's lots of amazing work going on in the physical activity sector in here. And this is just our experience of this. You know, there'll be colleagues up and down the country that have got their own experience. But we used to run lots of great initiatives for the sake of running them, I think, if for want of a better term. And actually, back in 2018, 2019, we took a fundamental look at our organisation and why we were providing those things. And there was a real shift from that point, because we made a decision that one of the key objectives of our organisation was to work as part of that local health system that was in place, and to become a willing and trusted partner to complement the activity that's going on. And complement is important for us, actually, because one of the things is, as part of that process, we established what we were good at, which is generally physical activity, and what were our strengths in terms of some community infrastructure, how we reach in our communities, but what we weren't good at as well, and how we would collaborate with other partners. So, for example, we have formal memorandums of understanding with people like Suffolk Mind around mental health, acknowledging that there's a specialist in that space in our local community. So there's been quite a lot of work before we got into some of the relationships around social prescribing. And I do not underestimate the time myself and my colleagues have been involved in meetings to make that happen. And we are now embedded virtually at every level within the local system, from both a strategic point of view, an operational perspective, and even in our local communities. So we run across 7 local communities effectively, and we have representation across all of that whole system now. So we've tried to embed the organisation before we actually did anything. And the other thing I would do, and maybe some physical activity sector colleagues will agree here, is we had to demystify what we were and what we did and why we were involved in this. And there is a perception around our sector and how it works. And we had to do quite a lot of explaining about how we wanted to contribute to this agenda before we sort of engaged fully. So apologies for the background, but I think that's useful context. But in terms of how we arrived in social prescribing, is we were doing a lot of work in this space. We spent quite a bit of time creating some relationships. One of our core pieces of work was actually creating an exercise on referral standard with public health in Suffolk and the primary care system. That built some trust and some opportunities to engage in the broader health sector. And at the time, there was a development where there was a pilot running in one of our localities for social prescribing. Now, in West Suffolk, which is predominantly where most of our work takes place, the local authority actually provides the LifeLink programme, which is what the social prescribing programme is in West Suffolk. And that's because they're best placed to do that. They had a really strong families and communities team. They understood the communities across West Suffolk, so they are best placed to deliver that. And our role really is to provide the physical activity support for that. And we've worked them over a period of time. We sit on their steering group. We help influence how the scheme is structured, but we also understand social prescribers meet individuals with very, very complex needs and very complicated and multifaceted, actually. And there are a number of drivers first before you address physical activity. So having a roof over your head and debt management and issues like that need to be addressed first. And we know we're not the number one priority. So we offer a support service around the outside of that. So when those individuals are ready, they can access our services. The practicalities of those services, basically, we have an arrangement with our local social prescribing team whereby they use our facilities as the base. And I think Helen quite rightly raised the issue about environment can be quite challenging. And it means that those people attending the social prescribing can get an introduction to our environment in a supportive way with someone who's most social prescribers mostly in a similar position, actually not necessarily always been within a local fitness facility or a leisure centre. So they base themselves, meet their clients, and on some occasions they will accompany those clients to some of the activities that are available to them to help remove another barrier. The other thing we did quite early is remove the cost barrier. So we know people pay for the services to, use in our local leisure centres and others. Some are free to access. We do have a number of free initiatives. But actually what we said to the social prescribers is that, look, you meet the people that are most in need. And they do, only about 20% of the people that they get referred to them are in employment. And a significant number of them have long-term health conditions. So they have some challenges, and they are definitely reaching those most in need. And we've said to them, look, if you think this person cannot afford to access our services, we trust you. And actually we have a system whereby they enrol the people on one of our traditional memberships that provides them access to our leisure centres, either supported or not, depending on the programmes they're engaging in. And actually they come into our leisure centre just like any other user. So they have a membership card just like anyone else. They swipe their card, it gives them access to the services that are available. We do identify them sometimes. They get a support mechanism through some of our health and wellbeing coaches that are there, depending upon what they're looking for. And some of them will be referred to our services in different ways and means. It might be actually they just want to swim and it's a swim on their own. They might want to engage in a different sort of group setting. They might want to do group exercise. They might want to use the gym. But basically, we try and create an environment where they're a user just like anyone else. And actually, we also onward refer if we think it's appropriate, both either back to the social prescriber sometimes and actually into other agencies. So we are co-located with musculoskeletal physiotherapy services. We have a strong link with the Public Health's Healthy Lifestyle Service. So we're just we're part of a very, very big network. And I suppose our role has been trying to embed ourselves in that network and just play our part and make a real difference to those people accessing those services. And we're seeing reasonable take up from that, and people are building confidence. And we are definitely seeing a growth in that social prescribing. And now it's across all 7 localities. We were only working in 2 initially, and the pandemic has slightly interrupted that in terms of how that work is going, but it's certainly going to evolve again on the other side of this. And just by that work, it's opening up all sorts of opportunities for our teams, whether that be exercise on referral, pulmonary rehab, COVID rehab. It's really quite engaging, the place we found ourselves in now.
You know what, it's great to have your panel colleagues there to hear this. Hear about what the sector, an example like this that the sector is doing. So, and it resonates highly that there's some partnerships, strong partnerships that have developed there. And I'm sure the audience are going to be quite appreciative of saying, look, we either have that, we need to develop that more, or we can do more. But I'd like to touch on that again with you again in a moment, Warren. Helen, I think you'll agree that the sector, from things that have been said there by Warren, for instance, can even have more benefits to public health than it does. But if we're going to truly integrate health and social care, and then be part of that strong community presence, how do you think we can do that? How do you think we can be a bit more accessible and integrated with that?
I want to start by saying I wanted to hug Warren when he was saying those things. It was really exciting, and it's a virtual hug, considered COVID clean hug, okay? But it was really exciting and positive to hear what you guys have been doing. And this is when I said about pockets of brilliance around the place, and I kind of want to clone what you're doing and try and bundle it and roll it out in other places, because it's really exciting. But sorry, Kenny, back to your question, which is about...
We will try to clone that, by the way. That is our vision.
Yeah.
We do that with James, yourself, and Anna and Warren to make sure that best practice is.
Yeah, more of that. Definitely more of that. And I mean, I'm sure there are people sort of listening in who go, "We do this."
Yes.
Which you can see everybody. And in a sense, it's one of those times where you want to see the audience say, "Come on, hands up if you're doing something like this." But so there's, for a start, people being at events like this, so you're listening to one another and sharing ideas, being inspired by one another. I think the salutary tale that Warren said, this was hard work. It took a lot of meetings to get this going. It took a bit of faith. I like the idea of using MOUs as a way of giving people a bit of confidence. I think, health and care being public sector are often full of people who are a little bit anxious about private sector, and many people view commercial interest as bad, public interest as good. And of course, that's so far from the truth, when we need both. We need both for society to function. We need both for health and care to function. And we definitely need both when it comes to the whole wider well-being picture. So there is something about opening up conversations, having a go. If you care about it, reach out. I think when I was sort of speaking earlier, I said about what's been fascinating to watch during COVID is how people have had a go and they've spoken to strangers. They've reached out, whether it's in their communities. I have WhatsApp groups of my neighbours that didn't exist at the start of this year. We never dreamt of it before. And now they're really rich and they're an extra source of help and support. Mercifully don't need it very often, but when they do, they're invaluable. And I guess that's a microcosm of what we're talking about here. What Warren's talking about is the reaching out. Somebody has to go first. And the vast majority of people are wonderful, trusting, amazing human beings who want to do the right thing. There's always a few idiots out there, but they're the exceptions that prove the rule. And if you do reach out, I predict 9 times in 10, you will be rewarded by a positive response. So be proactive, have a go. look at whatever Warren's doing. And I don't know how this is being disseminated. Perhaps Warren can tell us where people can read up more about what they've been doing in a way that's accessible to us all. I'd be interested in that. Sorry, I'll stop. I'm rabbiting on. I get excited, Kenny, you know that.
Good. That's good. We want excitement in the sector. It needs it at the moment. We are excited about opening up soon, various tiers, but we could use that. James, can I come back to you for a moment? I've got a gem of a question, a couple of gems of a question coming through on my text here as well that I might just put out to the group in a moment. But James, it's been great talking to you about some of the vision that you have for not just our sector, but other sectors as well, who will be, the Arts Council England and people like that. This social prescribing is about a conversation, isn't it? And there's something called a link worker involved here as well. What could you say to our audience about how the social prescribing model could work locally around these facilities, and how you envisage this community, other sectors as well, coming together to achieve your social prescribing goals?
Multiple questions there, which is great. I think firstly to say I'll join in the virtual hug for Warren, because it's an amazing example and brilliant work that's going off that embodies what we're trying to achieve here. Link workers, are relatively new for the NHS. A year ago, there was only about 300 link workers in place nationally. We've now got 1,300 link workers in place, and the aim is to have 4,500 across primary care as part of new roles that the NHS is investing in. So alongside health coaches and care navigators, we're going to have new roles in primary care that are dedicated to having that conversation with people. And I often say that I think conversation is one of the most powerful technologies that we have in the NHS, starting with asking people what matters to them, tapping into the assets that they bring to their own care, because people have lots of expertise that we sometimes ignore, and building a package around their individual needs so that we can get the best for them. So, that's the thing that the NHS is changing. And those link workers are going to be a crucial link out to communities. And the way in which I envisage it working locally, in answer to your question, is that I think we need new partnerships that just break down some of those barriers that have unnaturally existed in society for many years. Those barriers, not just between the statutory sector and the voluntary community sector and the commercial sector, sometimes between the commercial sector and the commercial sector, or the charity sector and the charity sector. The problems that we're seeing people facing in life, the social determinants of health, are not preserved just for the health sector. They're societal issues, and they're complex, and that's going to require complex solutions. And we'll only find the answers to that if we're working together, because the NHS doesn't hold all those answers. The expertise that lies within the fitness industry, the charity and voluntary and faith and community sector, and the NHS and social care as the statutory sector, between us, we hold the answers to solve those problems. So I think it is about new partnerships. What we're trying to do with our Thriving Communities programme that we've launched through NASP is try and get organisations working together across, as Helen mentioned, the zones of social prescribing. So whether that's arts and culture or sport or natural environment or advice sectors, how can we try and embody that as we're doing at a national level with the join up between the NHS and NASP and UK Active on this initiative? How can we do that at a local level? And Warren's given some examples of how that works. But, how can the local gym connect with the dementia choir, connect with the church and the mosque, connect with the food bank, connect with the local area nature reserve and the park room? How can all of those things come together at a local level so that they're working collectively to provide a link into primary care through the link worker and creating that range of activities that people are going to need? So that's the sort of vision that we're trying to create through the Thriving Communities programme. And it'd be really great to look at how we link the fitness industry up with that programme at a local level.
Yes, superb. The Thriving Communities programme, I had trouble saying that earlier, didn't I, as well? You must look that up with, maybe we can put the link on there. It's on the National Academy for Social Prescribing website as well. Anna, we know there's 1 in 5 people who use our spaces who are over 55. And we know that the workforce has got capacity, skill sets to engage more people in this age group. And there's some overlap as well with this age group and social prescribing, of course. Would you give any advice to our sector about becoming more inclusive to this group?
Well, I mean, I think as we've heard from Warren, there are obviously some great examples about, you know, how already you have reached out to the community. There is a big opportunity here, not only as I described in health terms, but actually in terms of an expanding customer base. We know that this is a growing proportion of the population, and yet in some of the polling work we did over the summer, amongst people 50 to 75, only 12% of those who are not members or users currently of their gym or leisure centre thought it catered to their needs. So there's quite a big, you know, perception barrier for you guys to overcome. And I think it does therefore, you know, require building those collaborations that we heard Warren describe with other community groups who are already in touch with these people, who know these people, who can build that trust and confidence and almost broker that, you know, stepping over the threshold if it requires a sort of going in. But the other is you guys going out, which again, I know because of facilities being closed, there's been a lot more of that sort of innovation happening during the lockdown. And I think really building on that as an opportunity to engage people who would not otherwise engage with your services. But obviously the social prescribers and the link workers that we've heard about today, I think provide a really exciting opportunity to also, you know, help to bridge those potential people who could really benefit from the services that you offer in the sector and overcome some of that sort of perception gap. But there are other things from the research as well, you know, like cost, practical barriers. We do have to recognise that in this older age group, it is more common, obviously, that they have a long-term condition or disability. And that plays into people's own fears about whether they should be, if it's appropriate to. And they also want to be really confident in your workforce, that they are going to have people in the trainers and coaches who really understand, you know, what works for people with disability and health conditions. So I think there's also a sort of challenge a bit back to you to look at your own workforce, not only look at the age of your workforce perhaps and think about, are there people that are going to be good role models for these people coming in for the first time who perhaps are less active, and also do they have the sort of slightly more specialist skills that they might need to really confidently support people with disabilities and health conditions. So I think, you know, these are all things that hopefully many of you are already thinking about. I know some of you are doing, and we really would love to work more with you. So, you know, do respond to the consultation that Kenny's mentioned, because we would love to be working with UK Active to identify some of the innovators so we can, you know, work together to evaluate how effective they are and to then sort of look at spreading so that the example that Warren described becomes something that we have across the country.
Thank you. Yeah, the space is there. There's people there to be used in this capacity for social prescribing, for treating people who are older with long-term conditions, who and it needs to be age, not just age specific, but you know, ability specific as well. So yeah, there's a variety of things that are going to start to come out in that consultation, I'm sure. I've got one for anyone really. We've got Liz Terry on the platform here, and she was saying, what do speakers believe the fitness industry needs to do to recognize the sector as an essential service by government? So a real light one for you guys there. And then there's a second question as well around what are we doing to measure the impact of health interventions delivered by the industry in a way that will resonate with the government? So both have a good bit of government in there. Both good questions. So first one, you know, what do we need to do, you know, to be recognized? And then maybe someone else can take the measurement, but Is anybody interested in tackling one of those about measuring impact? Helen, got your pen up.
Yeah, thanks. I've gone Anna had her hand up as well. I'm sure she's going to be very interested in measuring impact. So shall I talk about government? Would that be all right, Kenny?
Sure.
Recognition by government. So this is about being relevant. So what is government interested in? They're interested in being re-elected. Let's be cynical about it. MPs want to be re-elected, government wants to be re-elected and stay in power. They do fundamentally want to do good stuff and make the world a better place. Despite the cynicism we so frequently see peddled by daily newspapers, actually government and politicians are fundamentally people wanting to do a good job. Most of them are bright enough to earn a lot more money doing something else, trust me. And so it's appealing to their better natures, being relevant to the population, being visible to them. So do you know who your local MP is? How often are you in contact with them? Do they cut ribbons on exciting things happening in your gyms and your community initiatives? Does your local MP feel good about you, and do you feel good about them? Irrespective of the colour of your politics, that's not what we're in it for. This is about being known, being connected. And once you're connected and you have a dialogue, and then you cluster together to influence at a next level. So the grassroots is know your MP, reach out to them. How vocal are you? How visible are you in your community? Do you have a communications plan which goes beyond your immediate members and recruit more immediate recruits? Going back to all that Anna has said, this massive untapped potential that's out there, and your plan for the different groups in society. I'm struck by the CMO's brilliant charts for the different groups and their different exercise needs, but fundamentally everybody needs more of it. So you can connect with your link workers, you can connect with your local GP surgeries, you can connect with your local physio departments and your private physios and your NHS physios, because at the end of the day, we're all trying to do good stuff for people related to health and activity. You can shine the spotlight back on people like me and medical healthcare professionals and say, why aren't you telling people that exercise is good for you? You know, the single biggest, cheapest thing you can do to help the nation is to get them more active. We know there's loads of stuff about weight reduction and alcohol and smoking, which are incredibly important as well, but it's right up there. And there is almost nothing which isn't made better by doing a bit more exercise. And again, exceptions proving the rule. So, but back to making it relevant, making it accessible, speaking languages that politicians understand, talk about the people and the populations and relevance to society. If you want to do it at the next level up, you get people like the CMO to come and talk to you, and you talk to them, you give them something back, you collate information and evidence which is relevant to them. And I'll let Anna talk about how you measure stuff, because once you've measured stuff, you then feed it back to politicians and policymakers in usable bite-sized chunks. Learn their language. They don't speak the same language as you do. In the same way as a doctor, I talk a medical language, I talk the language of sickness with patients, but I've had to learn to talk the language of politicians, and the language of Treasury and Finance is a different language from frontline MPs. So become a translator of these languages. I'll stop there. You're all laughing at me.
No, not at all. Laughing with you. Thank you, Helen. Anna, did you want to have a comment on the measuring?
Yeah, I can come in on that. I mean, totally agree with Helen that in some ways you need to know who are you trying to convince, who's your audience, because, you know, what you measure and how you present your evidence is very much about, well, who are you trying to convince about the benefits? And as we've seen, you don't need to convince anybody really of the benefits of physical activity. There's masses of evidence showing the health and well-being benefits of physical activity. And also, I'd particularly like to stress the point that Chris Witte showed, which is actually getting those inactive people active. That's where the biggest gains are. This isn't about, you know, getting everybody who's already exercising to do just that little bit more, or maybe make those, you know, the minutes that we need to do according to the CMO guidelines. This is about those inactive people. So the evidence that we really need is, are you reaching people who are inactive? And are the ways that you then engage with them, getting them, first of all, to move from being inactive to active? So that's like the key thing to measure. Are you getting them active? And then are they sustaining that activity beyond whatever your intervention is? So it's not huge. You're not having to do any complicated sort of clinical or medical evidence. You know, as I say, that's all there. The health benefits of this are all there. So really focus on, are you reaching the people who are going to gain the most? And are they, you know, getting active, and are they sustaining their activity? And I think that's the key. And even for people, you know, your sort of local NHS commissioners who are always And NHS partners always seem to want to have higher quality evidence studies. And so they'd sort of like to know, if you're looking at your intervention, how it compares to people who've not been in your intervention and so on. So obviously there are things like that that can increase the quality of sort of your evidence case, but also look at the wider social benefits. We've been hearing about those from Helen and from James. You know, are people actually mental health better? Are they more socially connected? Is it giving them confidence? Is it helping them to get back to work? You know, for many people, you know, if they're out of work for a while, they get deconditioned and they're not even physically up for working. So, you know, there are all sorts of other wider social benefits that could really build a strong, you know, sectoral case, which is perhaps what you want for Treasury, where you're really showing those wider economic benefits, including, you know, how you're helping to ensure perhaps less demand for social care, something we started with at the beginning, Kenny. So very much getting the evidence for the audience and really thinking about, you know, what's going to be convincing for them.
Yes, I was going to come to you, Warren, because I'm sure you've got some local challenges, you know, with your business around measurement, and you've been asked some unrealistic questions, but perhaps have come back with some more realistic stuff. So it'd be interesting to hear your view. Yeah.
Yeah. So coming back to sort of the essential service and the influencing what makes us important in the system is, Helen makes a really important point around being relevant, and being relevant will be different depending on your locality and what you're trying to do. And I think it's really important that anyone wants to work collaboratively in this space really understands what's relevant in their locality, and that will be different. And across the 7 localities that we work, there are different drivers in each of those localities, different priorities, depending on that community makeup and how it works. And an understanding of that is important. And then how you pivot your service to support those things is also important then. And you may not actually in some scenarios be able to support. So you need to be quite innovative in relation to that. So, you know, how can you help with debt management and homelessness? Homelessness, you can provide a support service around that and help improve someone's mental health. But you have to pivot and change depending on how, you know, the local needs of that community. You know, and I think that's really, really important. And so are our behaviours. So our behaviours locally must, you know, we must really express ourselves as a sector that we want to engage with. And we internally in our own organisation, you know, my own organisation, we've had some challenges with that sometimes where we have had an approach from a partner and it's been a very difficult conversation to begin with, quite challenged. And actually, being brutally honest, quite financially orientated. And that's put that partner off and they walk away. So I think we need to change some of our behaviours at a really local level, because some of this work takes place very informally in a local community setting with a wide range of staff. So I think changing our behaviours in terms of how that works, and then influencing and myth busting, if I'm honest with you, with, you know, the sector's really keen around this gender, really wants to engage, and we're going to have to do that in a variety of ways, and embedding ourselves in the system is really important, and influencing. And I think Anna raises a point around, you know, data evaluation. There are numerous tools that we can use to influence, you know, people, particularly at a local level. And we use a wide range. But actually, that really hard data and insight that we're getting in terms of those evaluation mechanisms are really important. But so is some of the case studies and our peers, you know, the activities. And there's some really powerful stories. And when you're talking about influencing our local people, you know, and even persuading people to come and do this, there's some really powerful stories, and peer-to-peer is fascinating actually. And that goes, if you've got someone in the health system that believes you're really good and they talk to a colleague, that's great as well. The same as a service user, if they speak to someone else and they can encourage them to participate. Unbelievably powerful communication tool, and we need to build more of those. Amazing.
Yeah, great answer. Thank you. James, did you want to say something about that?
I mean, I agree with everything that Warren and Anna have just been saying in terms of the need for sort of new ways of measuring, really. I mean, I think sometimes we set a higher bar for the new and wonderful than we do for the existing. And sometimes when we look at the existing way in which we do things, there's not necessarily an evidence base for that. So there's a bit of a challenge there, because I think whilst we're trying to change culture to get people engaged in a different way of delivering health and well-being for individuals. We sometimes can fall foul of an evidence demand that is too high. And that's one of the things that we're trying to fix through the National Academy and the work that we're doing in NHS England is to look at better ways of articulating the evidence that already exists. Because, you know, as we've been saying, we don't need more evidence to convince ourselves that physical activity is good for us. And that is a really, really simple message. I think in terms of on a practical front, if colleagues in the industry are looking at things that they can look at, there tends to be three specific areas that I think the NHS responds well to. The first is patient-reported outcome measures. So are people happier? And Anna's picked up on a few things, you know, and their contribution to society better? Are they enjoying their life better as a consequence? The second is you know, working hand in hand with the NHS to see whether there is anything from a biomedical perspective that's happening to the individual. Has their BMI reduced? Are they losing weight? Is their blood pressure better as a consequence? Are they taking less prescription drugs? And the third element is whether or not this is saving precious NHS time. You know, is this reducing demand? And we know that people who increase their agency, who gain skills, knowledge and confidence in life will reduce NHS service usage. And, you know, the evidence points to up to 18% reduction in general practice visits and sometimes 38% reduction in admissions to hospital by increasing that skills, knowledge, confidence, by working with people to give them something different, give them that shift that they need to achieve the health outcomes that they're wanting. So just a few sort of ideas of those three areas that perhaps worthy of looking at.
Yeah. Can I just keep you for a second, James? I got a question here about social prescribing. Or anybody really, this is open to anybody, but social prescribing rarely comes with funding attached. How can charitable organizations provide services at scale without additional funding, and who should pay for this? So it's going to come up, you know, the sustainability of this. But yeah, we've got answers, I think, James. We've spoken about this before, but do you want to have a first crack?
Yeah, I mean, I think this is obviously, it's a really pertinent question, and we're shifting the focus massively here, so it's inevitably going to come up. The NHS pays around about 38% of the money that goes into social prescribing activities comes from the NHS in some way, shape or form. But as we've already said, the types of issues that people are facing in society, you know, at least 25% of people, and the evidence shows, attending a GP because of housing or relationships or social isolation, loneliness, debt, you know, not necessarily health-related issues. So the NHS isn't really the organisation that should be funding social prescribing in entirety. Back to, you know, my point that this is a societal issue, and I think, you know, multiple government departments and industry and others should be looking at how we invest in social prescribing as a concept in community activities. That said, we need to do more to join things up. So one of the tasks that NASP is working on alongside NHS England and the Money and Pensions Advisory Service, Sport England, the Arts Council and Natural England. So across those 4 zones of social prescribing, we're working with the arm's length bodies in order to look at new ways to attract funding for local communities groups. And we've just launched a relatively small fund, albeit it's £1.4 million in cash with the Arts Council. And we're going to be looking at a new way of getting funding to ultra local community groups that can support social prescribing to thrive. That's another part of the Thriving Communities Fund. And based on that, we then want to create the opportunity for shared investment funds across the country that are much larger sums to enable this to be rolled out nationally. So, you know, we're working at the moment on better models for funding this. But I think, you know, to think of this as a sole responsibility of the NHS isn't the right route.
Yeah. Helen, do you have a comment on that?
Or me?
Yeah, did you have a comment to that?
Yeah, and just picking up on the cross-government thing, you know, so James has articulated the NHS bit of it very well, so I won't repeat that. But I think, so for me, this is, at local level, this is about partnerships with local government. I mean, actually, local government does a tremendous amount already, but I mean, talk about a cash-strapped bit of the system. You know, if anyone's had money taken away from them, it'll be local government in your locality, and yet they still manage to do some remarkable things. And I've seen some great examples of where people who are local government funded, so libraries are a great example, have gone into partnership with other organisations, with churches and faith groups, and they've kind of combined resources to offer a wider range of services. So I practice in Lichfield in Staffordshire, and the library in Lichfield was going to close. One of the churches offered space for it. We've now got this thriving, buzzing community centre. The church, the library, and a whole host of other things are busier and more usefully employed than they ever were, which is fab, and it's created a real buzz around the centre of town. When the notice of the closure of the library was a tragedy, as far as I was concerned, you know, but it was the kind of seeing the opportunity in the tragedy. But local government do have an important part to play, because they're doing a lot already, but it's tapping in and optimizing what they're doing. And going back to Warren's thing about partnerships and reaching out, this is this stuff in action. You know, you had asked the question, Kenny, about influencing at the different levels, you know, so at the highest level, I mean, I'm certainly using my influence with NASP to start convening these cross-government conversations. And social prescribing is absolutely not just for the Department of Health and Social Care. There's Department of Work and Pensions, there's education, there's DEFRA, there's all these different places where people are thinking about this stuff and want to do the right thing. It's joining it up. So this convening power that we have. So for the very big organisations that are out there, is there something you can do with your convening power to start bringing things together? Who out there has got links into various organisations? And, you know, you've got some very influential people as part of your organisation and connected. You got with Sport England. You know, it's using those influences and ensure that the tap on the shoulder, well, it's not corridor conversations anymore, but it's you know, the elevator pitch. Are people ready to grab the opportunities when they arise to influence? And you'd be amazed how far that can go. And each and every one of us can do that, whether it's ultra local, whether it's national. And so back to that, empowering everybody to have a go at just reaching out, doing a little bit more, saying a bit more. And collectively, we have a really big voice when we all do this together.
Totally agree. And I think just one note on the sustainability of all this. Totally, I also agree, James, that the NHS can't foot this. Totally. And what we want to do is to bring examples like Warren to light. And there's another consultation that we're going to be doing, going out to the sector to find out what they're doing with the social prescribing. And we might find, and we already know about some, there's links to the NHS already that are out there. There are people being commissioned for falls prevention services. There are a plethora of things happening. We just need to join that all up. And correct me if I'm wrong, but bring that localism, that model to bring to commissioners and say, look, we're here. This is an evidence-based intervention for physical activity. So they may become interested in that way. But in order to do that, I think you guys have touched some good points. We need to join it all up. We need to make sure that it's measured properly. We need to make sure we bring those right conversations to commissioners in Lincoln. This is the beginning, as I said earlier in my opening, this is the beginning of us linking this sector to health. And it's the first time, it's a landmark moment for us today to have NHS England work with us in a NASP, in a partnership like this. So hopefully the audience will become inspired a little bit about that. I've got to just move on a little bit there now, but some of the highlights today, it's difficult to sort of wrap them all up in one or two sentences, but we've talked about the landmark partnership. We've talked about localism and partnerships vital for the success of this thing we call social prescribing, which I'm sure some of the sectors still getting their heads around. But basically, it's a non-medical way of helping someone's health and well-being, and that could be physical activity. There's opportunities to decrease health equities by making us more accessible, and that's what it's about these days as well. Now we've got one more highlight for you today, and he'll be coming up in a moment, but this is probably the last you'll hear of me today anyway, but not going forward, because I want to talk more and more about how this sector can be a front line of the NHS, and my colleagues are a bit bored of me saying that, I'm sure, but I think we can be. And with the sector opening up next week and something to look forward to in 2021, some final remarks, I think, from Hugh Edwards, our CEO, and hopefully Hugh is there.
Thanks, Kenny. Thanks all. That was a fascinating discussion point. So I really appreciate your time on the panel. That was a really interesting, stimulating debate. Kenny, well compared throughout the last 2 hours. Excellent job. So just some personal thanks from me. Thanks to the team at UK Active for organising this programme over the last 4 weeks. Our partners, of course, and also the speakers both today and across the whole 4 weeks of Summit this year. We wanted to create a programme of thought leadership and discussion and debate which would help support and frame the debate around the future of physical activity going forward. And I think over the last 4 weeks, you know, we've had different perspectives on that. We had the perspective from our politicians in week one, from central and devolved and local government, how they're looking to put well-being and physical activity at the heart of their decision-making process. We heard from the academics in week two and looking at how we measure the impact of the work of our sector, but also how we can develop an evidence base for future interventions as well. We heard from the experts on consumer behaviour, looking at the role that our sector can play in the built environment and the future of the high streets. And today we've heard from, as you can see on the screen, the leaders from across the health sector, and also with Professor Chris Witte at the start, to say that how can we as a sector integrate ourselves as fully as we can into the preventative agenda and provide a real service in supporting the NHS. A year ago, I stood on the stage at QE2 Centre and said that this organisation was here to support, protect our members and also to champion and represent them. And 2020 has felt that has happened in quite a considerable way, and also to support the growth of the sector as well. And you know, we've all felt challenges this year. This has been an incredible year on which we are in a state of continued flux and a continued change. I think the question for the sector, and it's been stimulated today and across all the weeks, is, you know, how do we approach that change? And I think it's up to us that we should be looking to lead the change we seek. We have made some 3 major announcements during this period of time as well. The partnership with the Advanced Wellbeing Research Centre with Rob Copeland and the team up there has been really important, how we set a roadmap for research in the sector going forward. Our active standard, which we'll bring in 2021, which will look to provide consistency, not across health and well-being issues, but also across wider societal issues. So we are maintaining the highest possible standards that we have as a sector, and be allowed to be trusted by the health agencies that we're looking to engage. And also the partnership today, which is a hugely important partnership for UK Activist members with the NHS, with NASP, and with Sport England as well. These are some of the projects and some of the ways in which we can lead the change that we are seeking, and to be at the heart of the national renewal we want to see in this country. This week is an important week, as Kenny has alluded to. Next week in England, we'll be able to reopen with some restrictions, which are frustrating, but it's a major achievement to get the sector reopen from next week. We are open in Wales. We still have challenges in Northern Ireland and Scotland as well. But this is all about now momentum for us. How do we take this momentum, the mobilisation of the sector with tens of thousands of representations going into MPs over last month, and take it into the next stage, take it into the need to get the necessary support for the recovery of the sector. And also crucially, you know, how do we play our key role in renewal of this nation? You know, a COVID-tinged world, you know, as Helen talked about, you know, we have to be at the heart of the renewal of the physical, mental and social well-being of this nation. And that is the real opportunity we have. The Chancellor has made some very challenging statements today around the future. And this is a sector where the government can really see the return on investment, you know, really significant return on investment across a multitude of areas. So this is the opportunity to build on the momentum we've developed over the last couple of months, to take that into 2021. And for the one ask I'd have of you and the wider partners and the members is to back us, back the team at UK Active, to take this energy into 2021 and let's try and seek the success that we all want to from a healthy and active society. So thank you very much. Thank you very much to the speakers. Enjoy the rest of the day and speak to you soon. Many thanks.
And I'd like to thank you very much for everybody joining us. Yeah, it's been a great discussion. Thanks for offering all of your opinions. And we're going to move forward with this landmark partnership. But I also would like to say, we're working with Centre for Aging Better as well for the first time in the capacity we are, and this is very important as well. And it all mix in to the social prescribing world. So thank you all for joining us today, and let's go